Great, well, thank you very much. Let me start by introducing the team. Jim Newton is doing our imaging today. Our anaesthetist is Mo, assisted by Corin. Our nurses are Sarath, Paul, and Wendy. Sarath is assisting me, Wendy's doing the device prep, Merlin's our physiologist, Helen is our radiographer, Alison from Edwards is supporting us today, and Jack, Richard, and Craig from the Stock Answer are doing the filming. So the patient we have today is 79. She's got severe mitral regurgitation. She is very symptomatic. She has orthopnea and paroxysmal nocturnal dyspnea. She has permanent atrial fibrillation, and she was felt to be at high risk for surgery. So she's been referred to transcatheter edge-to-edge repair. Should we start by having a look at the imaging, Jim?
Yeah, thank you, Sam. Good morning, everyone. Hopefully you can see the echo pictures on your screen there. Just to give you the overview of this lady's heart, she's clearly got very dilated atria. The left ventricle's visibly volume loaded. It is dilated by volume, less so by diameter. Both the mitral and tricuspid annulus are dilated, and there is severe MR. There is additional TR, but we're not going to focus on that for this case. You can hopefully start to see the posterior leaflet prolapse. This is pure degenerative MR. There's quite a broad, extensive area of P2 prolapse. So I'm just going to show you in this bicommercial view here. Most of P2 rides up above the annulus, and there's a single ruptured cord coming off the lateral side of the prolapse segment, which I can just show you if I just fix my orientation here. You can see that ruptured cord nicely there. And you won't be surprised to see the jet of MR coursing up behind the aortic root, extending round the atria. And it's clearly severe MR. There's definite flow reversal in the left upper pulmonary vein, which I'm just going to demonstrate to you now. And this is something we'll watch very closely during our intervention to hopefully improve the systolic waveform. The aortic valve is normal, the pulmonary valve is normal, and as I said, there is additional TR, but we're not going to review that here. So Sam's just put his wire up in the SVC, and I think we're going to move on and set up for the transseptal.
Thanks, Jim. Yeah, so where we've got to so far, we've got a 11 French sheath in the groin, 2 proglides. I've got a SL0 in the SVC. And my transseptals, I always do Baylis. So let me just show you the needle, if we could have the overhead camera, please. So this is the Baylis needle. It's not sharp, it has an RF tip. I always put a bit more of a bend on because these people tend to have quite a large right atrium. So if you put more of a bend on, you get better tenting. Sarath is just connecting that up to pressure and the box. So flashing that. Yeah, that's perfect. Thank you, Sarath.
And heparin's already on board, Sam, isn't it?
Yeah, ACT is 300. So I always give the heparin pre-transseptal. So I think we all do our transseptal slightly differently. I do it with the camera in PA. I'm coming down with the ports at 4 o'clock. Mostly this is done with echo, tiny bit of fluoro. So I'm high there, Jim.
You are?
And reasonably posterior.
Correct.
So for these procedures, much like MitraClip, we want to be probably mid and posterior. This lady doesn't have a particularly large fossa, so that's mid and fairly posterior, but it looks quite thick still, Jim.
Yeah, you're still on the slightly thicker part. You're still a little bit high.
So I need to just let it jump down. Not yet feeling it in my fingers. Once you feel the heartbeat in your fingers, which I'm starting to now, usually tells you you're getting down to the thin bit.
Any difference in your puncturing point, given that this is degenerative? We saw a functional case from Mike Mullen earlier this morning. Same puncture for you, or some differences? So
I think if there's a large flail, you need to be a little bit higher. I think that would be my comment. With degenerative, with functional, particularly where it's tethered and tethered into the ventricle, you can be a little bit lower. So, Jim, we're not quite on the thin bit there, are we?
Not quite.
So we're probably want to be a tiny bit more anterior, right?
Correct, yes. You're just a little bit posterior behind the fossa there.
So this is quite useful to see this because this is a small fossa, so being very careful with the steering. So all I'm doing is anti-clocking, and I'm coming down a tiny bit because usually anti-clocking alone doesn't transmit. And flash a fluoro from time to time just to see where we are. So I'm just creeping down. Yes.
Sam Sargadoshian on the panel. Can I just can you get you to just speak to the Can I just get you to just tell us what your views are on the NRG RF compared with mechanical? Why do you use RF. I'm a proponent of RF, but
yes. I think it gives you a great deal of precision and safety. Jim, I'm just going to come down again.
Okay.
It gives you a great deal of safety and precision. So that the issue you have with mechanical is that quite often these patients have quite tough septums. So if that's the case, you get there with a mechanical, you can't get through, and then you're sort of looking around for diathermy, you're looking around for safe seps or whatever else, and you never quite know that in advance. Flush, please, Sarah. Whereas if you use RF, you know whatever the septum is like, you'll be able to get through it. And the other thing is you never really need to push. The trouble when you push is that everything tends to drift superior. And that is not what we want in these procedures. You want to go through where you're tenting. I'm
a total convert. The other thing I was going to ask you is, have you had any experience with the VersaCross?
Yes, I really like it. So VersaCross is a RF. So Jim, I'm coming down a little bit more anterior this time, so that we can hopefully stay in that or land in the thin bit.
Yeah, so that's good.
Better,
AP now, and you're in the superior end of the soft thin part there, so that's looking good.
I'm just going to drag down a tiny bit, and then should we do a measurement there?
We'll do a measurement, yeah.
So yeah, VersaCross is a pigtail wire that has an RF tip, so essentially you do exactly what we're doing here. And then when you burn through the septum, you then just push it, and it turns into a pigtail in the left atrium, which is really nice. I like it.
So we are 4.1 to the, probably more than that, 4.5 to the base of the anterior leaflet, so height is more than sufficient.
And so for actually crossing the septum, always I want to see it in two planes, because if you've moved, if you've drifted, if you're not where you think you are, you get yourself into trouble later. Because in the four-chamber view, it looked like the septum was quite thick, but in this view, Jim,
you're fine.
Looks good, doesn't it?
It does look good.
And I don't think we need to be, and I definitely don't want to be any higher than that, and I don't think we need to be any lower.
No, we're good. I'm happy.
Merlin, are you ready? So Merlin, if you could buzz there, please. Yep.
That's across.
Lovely, thank you. I think we jumped across just before that then, but anyway.
Just before, yeah.
So what I'm doing is pushing everything across as one. Could we mag up on the fluoro, please, Helen? I'm now watching both echo and fluoro.
Favouring the appendage at the moment.
Yeah, so if I clock a bit, we'll point more towards the posterior. My dilator is nicely through.
It is.
And now that's the guide coming across. It's crossing nicely, and I'm now free in the mid-LA, right?
Correct.
So now taking out the inside part. So we now just have the SL0 guide. If I could have some kind of introducer. And then we'll take the super stiff next, please, Sarah. So what I'm going to do now is get this normal wire. So if the septum is tough, I tend to take the needle out and put a wire into the left upper, so that if it, as you push through, it follows the wire. If it's not, I tend not to do that. So this is my usual practice, what I've done just now.
On target for the left upper.
So I'm now, looks like my wire's in the left upper.
Definitely in the left upper. Nice loop there, easily seen.
So I'm just advancing my SL. Let's take that one next, please. Thank you. So this is a super stiff exchange length with a curve on the end. And so we're going to park this also in the left upper. So that's a nice loop there, Jim, by the looks of things. Sort of trying to go through the mitral valve, actually.
No, it's fine. You're just in the mouth of the left upper there. It's good. Yeah.
Good. Okay, so before we do anything else, let's get the stabilizer, just because that can be a little bit fiddly, so let's do that. So if we could, just fix the wire strap, that's perfect. So the stabilizer, this is the Pascal stabilizer. So it has a couple of ends here, which go on either side of the step that's under the drape. And then what we're going to do is click. Must click, otherwise it's not secure. And then these stabilizers keep everything still on the rail. And when you turn the lock, they're fixed. So it just gives you a bit more stability. So that's now in position. So what I'm going to do is pull back. I'm just going to advance the super stiff a little bit. So Jim, that's just the super stiff now.
Okay.
So some people use a safari wire for this bit, which is perfectly reasonable and works very well. I personally quite like this method.
Oh,
So
that's good.
the tail of the super stiff is not in the left
No,
upper, but
you're
that's fine.
coming in and out. That's fine.
Yeah.
So, it's a safe place to push.
Yeah. So walking everything out. Usually, the
Wire's good.
Pascal device delivers very nicely. It's very slippery, and although it's quite large, it is quite easy to deliver. We have some dilators in the room if we need them. Usually you don't, but I did notice putting the 11 French in, it was a little bit tough, so we've got them handy if we need them. So Sarath is just going to put this on the back end of the super stiff. So the tail end of the wire is in a slightly quirky position, Jim. But
Yeah, it's in the roof of the left atrium, but
the heel of the wire is in the right place, isn't it?
It is. Quite
So
happy.
delivering this, we're being very careful not to pull back the wire, which is perfect. Very good, Sarath. So what I tend to do is have a wet swab in my left hand, a dry swab in my right, so that I'm making everything nice and wet as I push. So predictably, it is a little bit tough to deliver. There we go. It's gone now. So I'm just advancing smoothly up, and I'll slow down once we get towards the septum. And
Tip of your wire's just gone through the mitral valve. It looks safe, but it's
I think it's fine. I'll push it up, so it's the heel should now be in the left upper, Jim, right?
It is. Yep.
Yeah. So
Well,
Jim,
actually it's just in the mouth of the left atrium, Sam. So just be careful there.
Yeah. Okay, I'm going to go through. You can let go now, Sarath. Thank you.
Yeah, you're close to the septum
come through
now.
the septum now.
Crossing there. That's gone very
feels
smoothly.
nice and smooth.
Yeah. Tips across.
And now I'm just going to fix the tip of the dilator and push the guide over it.
Yep, that's good.
And so now
Plenty
I
of
have
guide there.
a sharp edge to look at, so you can see exactly where I am by pulling back the dilator. So Jim, I'm going to pull everything back a little bit.
Yep, you're well across. Quite happy.
So to about there, and I'm
That's
going to
good.
lock the handle here. And then, actually I'll go in a tiny bit, just so we're nice
So
and
wire's clear. That looks fine.
Wires out. And so Jim, we're going to do
Yep.
Jim is going to show us a
Get into view.
slightly unusual view. So this is a feature that is particular to Pascal, where we get a septal on fast view, which we don't do that for MitraClip. So the septal on fast view took me a little time to get my head around it, because it's an unusual view. But what we're doing
Let's get a
is
better
putting the
picture.
mitral valve at the bottom of the screen, the guide at the top of the screen, and then we're looking straight at the septum. And the purpose of doing this is to make sure that the guide, if we flex the guide, is moving in plane with the mitral valve. And that means if we're aorta hugging, we can flex the guide and stop us doing that. And if it's in plane, then the movements are very pure.
So there's the mitral valve plane horizontal across the screen here. This is the posterior aspect. This is anterior, pulmonary artery and aorta. And there's our guide there. So we want it to flex cleanly and parallel to the mitral plane.
So usually to do that, you want the port of the guide catheter at about 4 o'clock. It's not bad, is it? It's pointing a bit down, isn't it?
Just a touch. It's pretty
So I'm
good.
going to go to about 4:15. That's better, isn't it?
That's much better, yeah.
So that's good. So I'll make a mental note of that. And what we will do now is deliver the implant. I'm doing a lot of talking, Darren. Is there? Can I have any questions from you guys or any comments?
We're still here, I promise.
Okay, good.
No, we're transfixed. Many of us don't have a lot of experience with Pascal, so seeing the differences in the system, I think, is important, and you're speaking to them very nicely.
Yeah, we'll focus on those, I think. Yeah.
So it's a good point about the trajectory of the sheath as you come across, because actually that does allow a lot more flexibility. What you find, if you get the orientation right, is you can move anterior post. You can correct the anterior trajectory quite easily without losing height. That's one of the advantages of this system. But it's getting your head around that 3D view, and it does take quite a while, I think, to get your head around what's actually happening with the guide across the valve. And what you do need is just a good 3D view, which Jim showed nicely there. So it's just there are minor differences between the systems, but they're quite important to understand, so that you as you do the procedure. But they are slightly different.
So Sam, can I ask what your strategy is then here, and you can talk us
Yeah.
through whether or not you're going to use a ACE or a P10 here, and are you going to go for 1 clip, 2 clip? Where are you going to start?
So I have a fairly simple algorithm for this. If there's too much tissue, I use an ACE. If there's not enough tissue, I use a P10. So that's not always the case, but by and large, that's what I do. So if, Mo, there's some blood for you if you like it. If there's excess tissue like there is in degenerative pathology, almost always ACE is the better option. If it's a very small valve, weirdly, P10 tends to give you a lower gradient. So P10 is bigger, but the effective orifice area is also bigger. So small valve might make me favour a P10, which is very counterintuitive. But so by and large, ACE for this kind of pathology, P10 for secondary MR usually.
I don't know what your proportions are, Sam, of use in terms of ACE versus P10. Our experience is to use fairly few P10s actually, and predominantly ACE for most pathologies. Is that your practice, or is it more
So
uneven
it's
split?
evolving. I might pause because I'll talk you through what I'm doing now, but it's evolving is the answer. So I think most people who are comfortable with MitraClip feel comfortable with ACE, and they feel a lot less comfortable with P10, and that was certainly the case for us. I think it's fair to say, Jim, we're using more P10 now, aren't we?
Yeah,
for
I think
secondary?
trying to understand exactly where it works, and you made the point well. The small valves, we've had some surprisingly, good results with just using a P10. So we are exploring the options and still learning.
But for secondary, mostly now we use P10, don't we?
Yeah.
I expect we'll swing in both directions and gradually find our, what we feel is the best for us. But that's how we do it. This bit is quite important because it's different for Pascal, and it's quite neat the way we can do it. So you can see the tip of my implant is pointing at the left upper pulmonary vein, and then it's in a safe place. I don't really want to go that much further forward than that. As I crossed, it was like that. I put a tiny bit of guide flex on just to get us off the aorta and pointing at the left upper pulmonary vein. So now what I'm going to do is keep the tip of the implant in exactly the same place. I'll give you some fluoro also so you can see what I'm doing. And I never used to do this, but actually it's quite a nice way of handling this. So all I'm doing is unsheathing the device. So I'm not pushing the device out, I'm pulling the guide back. It does not matter if the guide comes back into the RA, which it will. And I'm just watching the tip, making sure I'm not drifting forward, which I don't think I am I, Jim?
No, you're just close to the warfarin ridge there, you're fine.
So I'm coming back to that hard line you can see on fluoro. Actually, I'm going to go back a bit because I don't want to overcook it. So now I'm going to close. Yeah, go for it, sorry.
Sorry, question just for Jim. Do you use I noticed you were using some NPR earlier. Do you use a lot of NPR during your...
Yeah, absolutely. Certainly for the clip positioning, it's all done with NPR. For the Transseptal, definitely. For this step, I tend to use just a single view, so I can keep the tip of the clip in definitely in view. It's quite easy to think you're seeing the end and actually not. And obviously, it's important to track the tip of the clip, as it's crossing and make sure it's not pushing up against the back wall of the left atrium. But pretty much from this point on, it's continuous NPR and 3D.
So I've closed the implant until it clicks. I'm going to lift the sliders. And then can we go to RAO, please, Helen? Maybe 15 or so. And in a second, we're going to steer
Sam,
down.
your strategy here presumably is to just get as much as you can with the first grasp in the middle, or are you thinking you're going to go medial then central with two devices?
I think we're going to try. I'm slightly drifted out there. Jim, can you show me the tip of the clip?
Sure.
Great, thank you. My guide wasn't quite where I wanted it to be, so I'm just lining up everything there.
Yep.
So now what I want to do is, for this bit, I use quite a lot of fluoro because it makes it quite clear whether you're getting stuck. So I've got the fluoro and a bit of RAO, and I'm going to try and make this point down and right. And if you move it quite quickly, like that, it's very obvious if it's getting stuck. And as you come down, you turn, you torque posterior a little bit just to get off the aorta. Now I know that my guide is probably not in the left atrium because I did that unsheathing maneuver. So I'm just going to gently advance everything forward. And then now we're over the valve and we can start thinking about trajectories and strategy. So the easiest way to do this is to do one at a time and to start with the left one. So Jim, do you mind just talking us through the directions and landmarks in these two views?
Yeah, sure. So we set up with a bicommercial view in the left-hand window. So medial is on the left-hand side, P1 and the appendage are on the right-hand side. Pushing the whole system in translates across, pulling the whole system back, brings you back nearer the septum. And in the right-hand view is the 90-degree orthogonal plane, which, when we're fully in position, will give us effectively a long-axis LVOT view with the posterior leaflet on the left, the anterior leaflet on the right, then the aortic valve, and then the aorta. And we try and keep the apex in view as well, because determining the trajectory of the clip as Sam advances it out of the guide is obviously crucial to getting good alignment with the leaflets for a good grasp.
So it's fair, you look in the right-hand view, it looks like we're aorta hugging. However, I wouldn't make that judgment until you've sorted out the left-hand medial lateral trajectory. So I'm going to move a little bit more into the middle of the valve. And all I'm going to do, the implant is closed. Actually, let me just connect up the pressure while I remember. Thank you. So I'm going to advance the implant and see where it's going. Which way do you think, Jim? Drifting medial, right?
A little bit medial, yeah. We're slightly off the centre there.
So I use a bit of fluoro, because I think fluoro is really helpful just because it gives you an idea that you're more or less where you want to be.
Just slightly caught on the posterior there. You're free now.
You're free now, yeah. That's now drifting lateral.
It is.
I'm going to go and try and find a happy medium. Time spent here is not time wasted, because it makes everything easier later. So although you're desperate to cross the valve and do some grasping, this is looking fairly promising, isn't it, Jim?
Looking better.
It's a bit
still
medial,
a bit medial, yeah. Could just do another 10 degrees.
I think that posterior leaflet is stopping it translating that well. So it jumps. Try that. That's better, isn't it?
Better, yeah, that's better.
Should we go with that for now?
Yeah, I do like that.
If you look at the right-hand view, we are aorta hugging, and I think it's probably not a bad thing to be aorta hugging a bit because of the nature of the posterior leaflet. But it's probably quite nice to show you what the steering does. So we've got, remember we worked out where we want our port in order to get nice pure movements. If I put flex on the guide, which I'm doing now, and I'll try and keep in Jim's view. Do you see how the guide is now going much more vertically through the valve? And it's really nice that it translates very well and doesn't do anything else much. You sometimes have to take off a bit of flex, but apart from that, it doesn't do too much. So that's a nicer trajectory, I think. AP is,
yes,
Jim?
Yes, looking good. And you've just correctly come a bit more medial.
So that's still, it's pointing a tiny bit medial, isn't it, still? Not too bad, actually.
No, it's okay, I think.
You happy with that?
It's okay, yeah.
So we haven't got a huge amount of height, but I think we've probably got enough. So now we've got to more or less where we want to be. The trajectories are good. I'm going to open the implant. With the ACE, it often doesn't do very much and then goes ping like that. So it takes a while, a second or two to translate. So I think I didn't answer your question, John. We probably, I think it's worth trying to do this with one implant. However, there's a reasonable chance we'll need two. I think our first attempt will be with one implant. One thing that Jim spotted, which I'm sure we can have a look at in a second, is that there's quite a lot of chordae right over the middle of the prolapse, which might cause trouble. It might bash our implant and stop us orienting nicely, in which case we might go a bit more medial where there are fewer chords. What do you think, Jim? That's sort of 12:30.
Yeah.
You happy with that as a starting point?
Just on the medial side of the sort of main prolapse, you just see the ruptured cord peeking out to the left of the device. Orientation there, I think, is bang on 12.6, so it's a good starting alignment.
Good. So you don't need to do the kind of jiggling you have to do with MitraClip to get the torque to translate. But what I tend to do is, I'll show you next time we orient it, you do a kind of twitchy movement to make it translate. So what I'm going to do is drop the posterior class now, just to make sure that's the
Definitely
way we
posterior,
expect.
yeah.
So posterior is usually next to the port, not always, but usually. And then that's both.
Definitely both.
Then that's back up. And then with fluoro, actually you can't see on that view, but we can see that the clasps are coming up appropriately. You can see it very nicely in the right-hand 2D view there. I'm slightly over-opened, aren't I?
A little bit.
So I tend to cross-closed. I certainly would in this amount. I never used to, but I do now, because I think you interact with chords less if you do it that way. Certainly with the chords. Do you want to just show us those chords, Jim? Because it's quite...
Yeah, I think you can just see them coming into view
impressive.
On the right-hand side, if I just freeze the image there. So there's a couple of quite major primary chords, one to the tip of the leaflet and one just there on the anterior leaflet. It's directly opposite where the ruptured cord is. So I think we probably need to stay just medial to the ruptured cord to avoid there where If I just bring that into view, there's a chordy-free segment just there.
And so you can
Which
see
is not-
what Jim is showing there, that this is how I, as an interventional cardiologist, rather than an imaging guru, can understand what's going on with the valve is using these two views and moving the X-plane backwards and forwards. That way I can understand exactly what's going on in all parts of the valve. Sorry, someone was about to say something.
Yeah, those chords are exactly why you want to choose an ACE here over a P10.
Yes. So I personally feel it's better to keep things simple. So I think we're going to cross where we want to cross and see what happens. And if we're being bashed around by those chords, then we can regroup. But I don't want to overthink the first attempt, because very often keeping it simple is the answer. So medial lateral looks all right, doesn't it, Jim?
It does at the moment.
It wouldn't matter if it drifted a tiny bit medial.
No.
So I'm going to cross there.
Okay, it's crossing cleanly.
Doesn't look like it's hit the chords, does it?
No, not at the moment.
Given the anatomy that we've got, I'm not going to go too deep, because I don't want to invite trouble from those chords. So I'm going to go under the valve and keep under the valve as I open. And I'm coming up as I do that, just to try and stop it interacting horribly. And it looks like the leaflets are sitting on the valve, on the implant anyway, so that's a good start.
Trying to.
So just to talk through some of the features of Pascal that are unique. The fact that you can independently grasp, which is obviously available on Gen 4, but that's not widely available in the UK yet. So independent grasping we use all the time. This is probably some anatomy where you quite often don't need it. You very frequently need it in secondary MR. Pretty much always need it in tricuspid procedures. That's looking pretty good, isn't it, Jim?
It probably needs to clock a tiny
few
bit,
degrees.
doesn't it? Yeah. Just come back
Just to go through the
11:30.
talking, would you mind just showing my hands for a second? If this is quite difficult to sort of put into words, if you could show echo as well. What often happens is that you can talk further than you need to go. It doesn't translate, and then it translates later, which is a real pain. So what I tend to do is decide where I want to go, which is clock a few degrees, and just sort of talk back and forwards until it does that.
That's it.
And that's kind of gone. And if you do it with a repetitive small movements like that, it tends to go, and it tends not to go too far. So slightly trying to go back, isn't it, Jim? But that's fixed, I think.
Looks nice.
So the other thing is, Jim, I'm hoping we can show elongation. It would be a real shame not to, but I don't think we need to at this point.
Not at the moment.
So posterior looks nice.
Yes, it does. It's nicely on.
Anterior is nicely on too, isn't it?
It is. Both nicely
I'm
on.
just going to come up, and I've been watching with one eye the left-hand view to make sure we're not drifting. So coming down really slowly, so you
Both
can
nicely
see
in.
for sure that you've got both. The temptation is to slam the glass down because you're so excited you've got the leaflets, but actually don't do that. You want to watch them going in. Now, whenever I'm thinking about how much I'm going to fiddle, it kind of depends on how easy it was. For an easy grasp, we want perfection, don't we? So I would move around. If it took half an hour to grasp anything, my inclination would always be to close and try, because you don't want to lose what you've gained.
The other thing to think about here is there's a lot of mobility on that segment. So you might be putting a second device in for stability rather than to treat MR. So you just need to make sure you've got enough space to put a second device in, medial or lateral. You've got plenty of space here, and that the clocking of the device is correct. But this looks pretty nice. So
yeah, I think the orientation looks pretty good, doesn't it, Jim? Are you happy?
No, I agree.
with
It's
it as it is?
12.6. We're just on the medial side of the prolapse, but we're pretty much in the centre of the valve, aren't we? So this is where we're aiming for. So we can check our leaflet in position if you want, and then
Yeah.
And Sam, do you close on colour to just see the change?
We tend to. I mean, if you're not sure about the grasp, we tend to close off, or sometimes we close off colour just to see the leaflet being drawn in, particularly in tricuspid. We do that. So should we do some optimizing, Jim?
Yeah.
So the two features that I think are useful with Pascal, the first one, which we may not need to use here is elongation. So if I open the implant and keep opening it, it becomes straight, and it then has no sharp edges at all, and you can get out. So with this device, you really don't ever get stuck. And if you're doing a procedure on a patient with, say, a shelf of severe posterior mitral annular calcification, you feel a bit anxious about getting stuck, and you just won't with a Pascal. So elongation is something we use all the time and is really useful. And if we were being bashed around by cords, we definitely use it and have a low threshold to elongate, come back into the LA, sort out the orientation, and recross. And we do that all the time. The second thing that I think is really useful is what I'm going to demonstrate now, which is optimizing. I mean, both look good, didn't they, Jim?
They do.
But it might be nice to get a bit more. Should we just do both?
Yeah, let's start with the anterior and then.
Yeah. So with optimizing, you want to steer towards the one you're optimizing before you open the clasp. So for anterior, I'm going to anti-clock. So I'm favoring anterior. I'm just going to lift up a bit, I think. And then, always good if you remember to open the correct clasp and that the pin is out. If the pin is out, they open one by one. So I'm now going to open anterior. And do it really nice and slowly once the view's stable so that you can see. So that's well in, isn't it, Jim?
Yep, nicely into the apex
Just
there.
going to give it a tiny bit more anterior and lift it up a tiny bit just so we get a tiny bit more and then drop slowly. That looks good, doesn't it, Jim?
Nice grasp.
Now I'm going to do the opposite. So we're going to go over towards posterior. So putting a bit of clock on. I'm not going to lift up anymore, actually, I think. And if it falls out now, you feel slightly upset, but actually it's much better if it does now because it tells you didn't have enough in the first place. So posterior coming up now, Jim.
Okay. And you've got plenty in there
Passes
again.
in there, isn't there? So I'm
just dropped out, Sam.
Okay, so that was worth doing. I'm going to try and get it in as it is, but if not, we just open and regrasp. There, it's trying to get in, isn't it?
Almost.
Not quite, is it?
No, it's just coming
And
past.
it's better, we do, in tricuspid, we tend to time it. I tend not to in mitral because that wasn't a difficult grasp. So I'm just going to open both, Jim, and we'll just come up again. Okay, so let's just recheck orientation. So that's sort of annoying that happened, but it's not a disaster, and I'd much rather make sure we have enough implant rather than chance it.
Sam, do you do much ventilation holding to optimize your grasp?
Occasionally, but rarely. I think with the clip arm length that we have now, it's pretty good, isn't it, Jim?
Yep, that's 12 and 6. Good position.
With the clip arm length that we have, I don't think it's needed very often. I mean, when we were using NT for secondary MR, then we used, what I quite like doing was using intravenous GTN, actually, because that drops the LA pressure.
I have to say, we've never found it very useful,
No.
but the centre in Germany said that actually reducing the tidal volume was actually much more.
Yeah, quite a lot of people
effective.
do that. Yeah, they reduce it to a very small tidal volume. I think we've got both there.
Both are trying to go in there, yep. Both look good.
Just wonder whether we've rotated a tiny bit.
I just wondered the same because my view has
I'll
changed.
pause then. Let's just check. Just because I wasn't easily seeing both arms.
It's a tiny bit anti-clock, isn't it, from where we started?
So I'll just fix that. Any hint of any trouble that it's not turning, just elongate and come into the LA. But it's turning very freely, so I think it's fine.
It's probably gone a bit to 11:30 now.
Yeah, it's coming.
It's a great demonstration of how useful MPR is, real-time MPR, Jim. This is
Absolutely.
And it's drifted a bit lateral, Jim.
It has gone a bit lateral. No, I agree. It's the most useful tool, I think, actually. I mean, 3D is nice, isn't it, for the orientation, but the MPR and being able to track the X-plane through the clip as it's moving, makes all the difference to know where you are and what you're doing.
It's great views, Jim.
Better, isn't it? I'd knock it in a tiny bit. How about that?
That, to me, looks 12.6 and back in the centre.
Just whenever you're moving it under the valve, just to flash your fluoro, just to make sure you're not getting funny curves or stored tension. So I'm above the posterior leaflet, so I'll get under it. And I may get my wish of showing you the elongation, which I should perhaps not have wished for.
Anterior's well in. Anterior's good. posterior is probably going to need a bit of optimizing.
Trying, isn't it? Should we just fix that now?
Yeah.
And then we'll check orientation.
Actually,
It's in,
it's
isn't it?
loads in. Yeah, that's good.
So I just optimized a bit, but let's, before committing, we'll just check orientation again. But although this can be fiddly, it's extremely hemodynamically benign, and it just, you know, a little bit of back and forth and fine tuning here and there does make quite a big difference to the end result.
So it's 5 degrees off compared to a clocking we wanted, isn't it? But it's actually bang on the right part of the posterior scallop. So
Yeah, I don't feel
The other thing
strongly that I
about
want
this
to move it.
orientation is it looks like you've got more of that degenerative segment in.
Yeah.
So with the other orientation, you had a bit of flail just above it. You haven't got it here. So it
Yeah.
might be better, actually, with this slight
Yeah, it's a
blocking.
fine line between perfection and pragmatism, isn't it? So I
That
think
tiny-
this is probably pretty good. What did you think of anterior, Jim?
anterior was absolutely fine, Sam. I saw loads of anterior.
So should we close there?
That's close.
Okay, so can we have a look at hemodynamics as well, just while we close? So we're in an EP lab, so the scale is completely incomprehensible to me, so just look at what happens to the waves. I think the V wave is about 55, and the systemic pressure is about 95. So those numbers are important, so I'm going to close now, Jim. Unlike with MitraClip, you don't need to give back tension at this point. So that's closed.
Okay.
V wave has halved, I would say. Actually, more
It's
than
a nice
halved.
reduction in colour.
Systemic pressure has gone up by 25. I mean, that's quite a striking change. So, I'm just going to check that my steerable is neutral. Interventional cardiologists like to fiddle with stuff, so I tend to fold my arms and stand back and let Jim do his assessment. So
The first thing I tend to look at is on the right-hand view. Can I clearly see leaflets going into the clip? Can I persuade myself it's nicely grasped on both? And here I can. You can see a bit of the dental floss just coming into view there. That's not anything to do with the valve. That's the device. Don't be alarmed by that appearance. Next thing I do tend to check early is a gradient. I'm not expecting it to be at all a problem here, but of course if the gradient's borderline, it starts to tell you about how much more options you might have in terms of moving the device or changing things. I can see by eye the gradient here is going to be no problem at all, but we're just going to measure the mean gradient through the mitral valve, and the mean there is 3.4. Colour's useful, but it's never the main thing because you often get a spray of colour up around the device. I tend to favour looking for change in the pulmonary veins, change in the left atrial pressure on the V wave. So here's the left upper, which I think I demonstrated at the start had clear systolic flow reversal. Just going to pulse wave back in the left upper. And we have no flow reversal, and we have a hint of forward flow. So it's blunted for sure, but it's definitely better than what we started with. So we had an appreciable reduction in the grade of MR. We've got nice leaflet insertion. Next thing I then do is walk through the valve with the MPR. Start on the medial side over near P3 and just come through the valve, come into the clip, and I'm looking on the right hand screen what the leaflets are doing. I can see the leaflets again coming into the device nicely there. Walk through the device and come past it. You can see the residual prolapse, but actually the ruptured cord is contained. There's no obvious large visible gap there. So I'm happy that we've got a good grasp of the posterior leaflet and a good reduction in the MR. Gradient's not a problem. The residual MR you can see there is coming through on the lateral side, immediately adjacent to the first device. And there's
Do you
another
think there's a bit of medial jet as well, Jim?
absolutely. You're just about to highlight that. There's a sort of medial sort of spray coming up alongside there. And I think they're probably about equal, the residual medial and lateral jets. So this is where
one of the
sort of,
issues.
go on.
One of the issues sometimes, Jim, is the significant movement and mobility
Sure.
in terms of tearing leaflets, single leaflet detachments, and so forth.
Yep.
How do you assess that at this point, or is it something that you worry about after deployment of the clip?
I think it's extremely difficult to assess at this point, isn't it? Because you've got the clip, the device held by the delivery system. For me, it's all about the grasp and how much posterior leaflet you think you got in there, and how how close you're sitting towards maybe the apex of the prolapse segment. To my eyes, we're off to the side of the prolapse segment. So I think this clip will be mobile, and I'm probably expecting we're going to put a second clip alongside it. I'll hear Sam's thoughts in a minute. But the real, it's sort of stick or twist now, isn't it? Do we think we can get this first device in a better position? Do we need to chase that medial jet? Or do we take this as our good starting point and hope that with a second device alongside it, we bring the MR down to mild? That's the debate. I think stability, is very hard to anticipate.
So I think we have Francesco Maisano online. Francesco, what are your thoughts at this point in terms of the position of the first clip? Thoughts about a second clip or necessity of a second clip to stabilize the first?
Well, I think a second clip probably should be considered. I always make this consideration after I release the first implant. So this is a general rule that you only can really understand what's going on after you detach from the delivery system. There is for sure a significant residual MR lateral to the clasp. Pascal, lateral to the Pascal, there is still some prolapse, some flail leaflet, and this is the situation where you may try to get another grasping somewhere else to see if you can incorporate the flail leaflet in a better way. There is still quite a lot of mobility of the base of the flail segment. The other, I also have a little bit of I'm a little bit uncomfortable about the medial jet, which may underline some little degree of distortion. So in these cases, I would have a very low threshold for repositioning and try a second implant. But obviously, this is more. I know it's easy to say from here. It's a decision that has to be taken by the operator with all the feeling that you have having the hands-on. So it could be also acceptable to leave the first implant here and do a second one.
Yeah, so I think I'll just chip in with my thoughts on this. I agree entirely with Francesco that you don't really know until you let go. Our experience with Pascal is that when you release, usually the MR gets a little bit better. So it may be that one or other jet looks less impressive after we release. It wasn't a difficult grasp. We could move more medial. However, we know there are all those cords there, and I don't like to look a gift horse in the mouth. Systemic pressure has gone up by 35 millimeters of mercury, which is a pretty spectacular hemodynamic result. This lady is not going to have orthopnea and PND anymore, even if we do nothing else. So I will allow myself to be guided by Jim, I think.
So what I'm hopefully demonstrating here is that there are convergent zones either side of the first implant, but to my eyes it's dominant on the lateral side. There is a medial jet. It doesn't look significant to me at the moment. It could change as the device is released. Personally, I'd accept this, release it, see what we've got, and probably expect to put a second device lateral to the first.
That's my view. And we could, ask 10 cardiologists, you'll get 10 answers, I'm sure. And we could easily move it more medial, but knowing that big lump of cords are there, and we've actually had a pretty easy time on that front, I think it's probably worth taking this. So on the release, Jim.
Happy.
Okay, so I can perhaps go through the release if we could look at my hands. So I'm going to cut the sutures, 1, 2. Quick flash of fluoro to make sure nothing's under tension. And then, so I'll just show you that. So you can't see, I haven't got any crazy bends on and nothing is bowing. Then I open the 2 ports, pull out the sutures. They should come out freely. If they don't come out freely, it's usually because you haven't cut the one furthest away from you, which took me a while to work that one out. Next thing we do is pull out the pin. This is the blue release pin. And then if we could go back to this, if we could show my hands and TOE, that would be great. Actually, hand TOE and fluoro would be good. So with ACE, you have to turn it many times in order for it to release. And I tend to use my index finger as a brake to stop it spinning back. So I'm turning, letting it come back a millimeter, turning some more, coming back another millimeter or so, turning some more, Let's get in there. We're just off there, Jim.
Off there.
So I'm getting the implant catheter back in so that it's not causing any risk, and then I just stop and let Jim do his assessment. So what we can see is it's all nice and stable, isn't it, Jim?
Yeah, the first thing I want to check is we've got a good tissue bridge. We haven't had a detachment off either leaflet. The device orientation still looks the same, so it wasn't under any real torque tension when it was released. Can still see the prolapse segment of P2 lateral to the first device, and you can just about make out where the colour is going to be coming through. Gradient is clearly not going to be an issue here. We can see two nice big orifices either side of the valve. So the real question for me to address right now is has the medial jet changed at all? Perhaps it is slightly more prominent there. It's a bit further away, isn't it, from the device? But the lateral jet to me still looks the bigger component, particularly if we look at the colour coming up there.
And just to add the other bits, the hemodynamics haven't changed, so the V-wave hasn't moved, nor has the systemic pressure after release.
And I think there's a reasonable target there on the right-hand screen where there's a visible vena contractor. And we've got leaflets there, albeit with chordia adjacent to them, where we could potentially look to grasp again.
So Sam, Jim, can you just give us, so even if, just supposing there was no residual mitral regurgitation, would you be tempted to put a second device in for stabilization purposes, as we've discussed, to reduce the risk of SLDA?
We tend not to, actually, don't we? If it's really there is not residual MR, if there was some, we would. But if there wasn't, if it was mild or less, we generally don't, do we?
We don't. We've never done that. And I think what I like to do if we're debating that point is go back to the save loop of the leaflet insertion and just really critique that and say, is the leaflet fully in? Have we got a really good grasp? And if we've got a really good grasp, and yes, it's bouncing up and down a bit, I'm not worried about single leaflet attachment in that situation.
Jim, can you just show me how much guide we've got?
Sure.
So I'll just show you changeover. So Wendy is nearly ready with the next implant. So what you don't want to do is fall into the right atrium, because that's a little bit upsetting. So I'm just going to, that's the guide just further back, the harder white line. So that's tip of steerable and guide.
About a centimetre or
so,
yeah.
Right?
Yeah, that's going across there.
So I'm just pushing it forward because you don't want any surprises on that front. And at this point, it's quite good to take off the guide flex. So I'm coming out with this implant. The stabilizer is locked so that I don't inadvertently creep back, but I'm still also fixing it with my hand. And this time I use a lot of fluoro just to make sure nothing is moving, because it's not a disaster if you fall out into the RA, but it's annoying. So thank you, Wendy. Wendy has got another device ready for us.
So, Sam, let me just update you where we are in terms of timetable. We have some rumbling tummies here, and we're due to leave you guys for in 5 minutes to get some lunch. Having said that, I think we're all quite interested in seeing the outcome, and so we really have two options. One is to stick with you for the next 10-15 minutes and see can you get the second clip in, though not wanting to put any pressure on you. Or the second option is that we come back to you in an hour and see the final result and see what you guys have achieved.
So I don't
really,
want
this
to...
is a decision you should make.
I don't want to tempt fate, but usually second implants are relatively quick. Would you agree with that, Jim?
Yeah, I would. I mean, I think I'd probably say we start with the first suggestion that we keep going. But if it's clear we're getting into trouble and elongating a lot and it's going to be painful, we'll switch off and come back later. Okay. Depends how hungry everyone is, really, doesn't it?
Yeah.
Okay, Sam. So no pressure. We're going to stick with you, and excited to see how the second clip goes.
And I think it's the kind of discussions we're having here are also important for referrers to hear, because what you don't want is for the patient.
Bit of flexion.
Thanks. And what you don't want is for the patient to go back to either their cardiologist here or their referring hospital and to be told there's residual MR, the procedure didn't work, one of the clips must have fallen off. And I think being very clear that, even if there's some residual MR, we've left the patient with, say, can we go to PA, please? S-dominant flow and no V-wave. These things are quite important. The colour is not a hugely useful guide to residual MR. So, same again. Go over towards the left upper. You happy with our direction, Jim?
Heading for the left upper, nice and
it's the same deal
clear
as before. I won't let it go any further than that, any further forward than that, and I'm going to unflex a tiny bit. There we go.
Yeah, that's good.
So coming back, I'm doing this unsheathing thing again, letting it drift forward a bit, closing the implant, making sure that's free of everything, isn't it, Jim?
Nice and clear, mid-day.
And as we close, everything shortens, so you can advance as you close.
Yeah, that's good. Fully closed.
Fully closed, clasps up, and pressure is connected. REO, please, Helen. So can go on a tiny bit. My ports are all still in the same place, so nothing is drifted.
Clear.
That's moving nice and clear.
Yeah.
A bit of posterior torque to get off the aorta. Now, obviously, I have a landmark to work with, so I'm going to make myself parallel to the other one. And on the lateral side is what we're going to aim for. Something like that. Just going to move a tiny bit further away, Jim.
Yep, so you're definitely lateral.
And I'll just put that steering back on, shall I?
Yes, you are going to need to do the same, aren't you, to come off?
This I will do on fluoro, because you usually have to take a bit of flexion off as well, and I don't want to bash the other clip. So lots of small movements and just fine-tuning.
Yep, trajectory's looking better.
Go a bit further across and then flex more. How about something like that, Jim?
Yeah, good starting
Looks all right,
position.
doesn't it?
Yep, does.
So I'm not seeing any tension or funny bends on the fluoro.
No, it looks clean.
So I'm going to open there.
So we can see that you're probably about 60, 70 degrees off. Rotating nicely.
So just another point about rotation, also making sure I'm not bashing the other clip, is you often need to do a bit of counter traction. So I'm doing a bit of anterior torque on the steerable so that the clip's not dancing around too much. So that's parallel. It looks a bit close to me. Should we go?
Yeah, it probably needs to be advanced in a little bit,
across.
doesn't it? That's better. Can see a bit of separation there.
So that's 12, 15 or something, isn't it, Jim?
Yeah.
So checking the clasps.
Posterior.
Posterior is as expected. Anterior, or both, sorry. That's good. And just looking down from above. Just going to let it drift
This has come medial a bit, doesn't it?
back a tiny bit. Something like that?
Yeah.
Just clock a bit as well, sorry. Let me just sort that out. So second clips is probably when I might use a respiratory hold or a ventilator hold. Okay, happy to cross, Jim?
Happy to cross.
So I'm going to close. Here I use a bit more fluoro than I would otherwise use. Just because I want to be really close, really parallel, and not interacting.
Looks good.
It's looking good so far.
Yeah, you are. Just about under there.
And a sort of thing that we've started doing is don't go too deep at this point and open. And as you open, come up so that you're staying relatively in the same place, not going miles under the valve. Because if you do that, then firstly you must be parallel by definition, and secondly you don't tend to lift up the other implant. So we're now under the valve and coming up towards the valve. So we need to clock a little bit.
Needs to clock 6, 7 degrees. So it's done there.
So second implants, particularly the anterior leaflet, often shadowing is much more of a challenge. But actually that's lovely. So
Both look nicely in.
I'm going to come up a little bit. It's just a balance between coming up as high as you can, but you don't want to put everything under a huge amount of tension. So I'm drifting up a little bit. That looks all right, doesn't it,
It
Jim?
does. Both are nicely sat on. Good insertion of both.
So clasps coming down again, resisting the temptation to slam them down. Can I just show you posterior again? I think it was fine.
It was definitely fine.
Yeah. So just show me 3D on fast, and as long as that's okay. They tend not, when they're this close together, they tend not to turn very much, actually.
Might have clocked a little.
It has, hasn't it?
Yeah,
and that's easy enough to fix, isn't it? Should we just do that?
Yep.
So just allowing it to go in a tiny bit and drift So very small movements when you're this close. More like that.
So Sam, Jim,
Better?
are there any
Go for it, Saga.
Are there any tricks for reducing the shadowing from the first clip? Any movements of the
Work with
probe
Jim
that
is the
you
answer.
would,
It is difficult. Just getting a view where you can try and get the delivery system out of the way, and often it's going a bit further in and tipping the whole atrium across and coming from the side. Sometimes I have to go to a single view. It's difficult sometimes on NPR, isn't it, to get a clear view of the anterior clip. Here I'm lucky I can, but sometimes going to a single LVOT view and withdrawing the probe and putting lots of anti-flexion on helps. But as you know, everyone's different. Everyone's atrium's in a slightly different position, and it's often the hardest bit.
In the LVOT view, you've got perfect views of this second device, which is just, it's not often the case.
Yeah. Are you happy with anterior, Jim?
I'm very happy with anterior, Sam.
Should we close?
Why not?
Yeah.
Just closing very slowly. So V-wave has come down about another, actually half. V-wave has come down another 50%. The systemic pressure is just drifting up again. Yeah, this is another 15 of millimeters of mercury. Just to finish, while Jim's doing his assessment, Saga, just to finish that point that you were making, in the last resort, which we've had to do a couple of times, if you really can't see, what you can do, it's usually because you've got loads of guide in the left atrium, and it's because you're doing complicated steering. You can sort of unflex and pull the guide out, so your trajectory isn't what you would normally want it to be, but there's a lot less guide in the left atrium, and so that's another trick. So pull the guide out and unflex a bit, so you're still in the same place with a slightly different trajectory and less guide in the left atrium.
So 3 important
That's
things
really
to notice: that there's smoke now in the left atrium, which is a good sign. The mean gradient has come down, which tells me that we've influenced the regurgitant volume quite significantly. Forward flow looks to be starting to appear in the left upper. I'll just get a slightly better view. And I think you also saw on the colour that colour is looking good as well. And on the 3D, there's a good tissue bridge again and good alignment of the device.
So the blood pressure is
we are
now
seeing some
super
forward
physiological
flow
for her. So important when you're
better.
assessing to make sure the blood pressure is, particularly with secondary MR, this is an issue. They become quite hypotensive under anaesthesia, and interesting, the medial jets disappear, doesn't it? They come quite hypotensive under anaesthesia, so it's worth making absolutely sure that the blood pressure is as it should be when you're assessing gradient and residual MR.
Sam, that looks like a fantastic result from that second clip, and overall, what a brilliant outcome for this patient. We have one final session before lunch, so we're going to move on. Any final comments for us, Sam, before we thank you and the team for a fantastic demonstration?
No, it's a pleasure. Well, thank you very much for inviting us. Thanks to all the team here. Thanks to my friends in EP who gave me their lab for the morning. And I'm going to join you later on for the tricuspid session. So thank you very much and see you soon.